Thanks for joining us. My name is Hubert Zajcik, and I run Health Wildcatters. Those of you who will be at our reception tonight will see our offices on the 13th floor later. So it's a pleasure to be here and talk about AI. Dealing with startups, there's almost no day you don't get AI thrown at you, and there's lots of war stories on how you can build that into the title of what you're doing or into your company name or other ways to mention it. But specifically our topic is first do no harm. And of course this is taken from the Hippocratic Oath. And if you were to look that up, that's probably the most famous piece, but that's almost 2,500 years old that Hippocrates was around. And the main tenets of the oath that physicians, and I was trained as one, swear is to act to the benefit of the patient, maintain confidentiality, and then do no harm. And so these are the things that we will be discussing today, because as some of that power gets transferred to software, to AI, how can we ensure that things don't go off the guardrails, go off the rails? How do we build some of that into the treatment of patients? And so we have a great panel here. I'm going to let each introduce themselves, and then I would also like to maybe let each of you at the time give us one most pressing topic for you or challenge that you see in your world. So we'll start with Ruben, and we'll go down the line.
Well, it's great. Very excited to be here, and thank you for putting this panel together. My name is Ruben Amarsingham. I'm founder and CEO of Pieces Technologies, and my background is I'm a physician and practiced for many years in internal medicine, just across the street at Parkland Hospital and UT Southwestern. And my background also is in biomedical informatics, and Pieces Technologies focuses on trying to support doctors, nurses, and case managers in the inpatient environment with a lot of their documentation needs and tasks and communication. So it's been a lot of fun. I think the most pressing need is probably what we're going to be discussing quite a bit to me, which is, unlike in my view, unlike other fields where generative AI and AI technologies in general are emerging, errors using these kinds of technologies within the healthcare could be obviously very catastrophic, and especially in the inpatient setting, where you have individuals that are quite sick, very dynamic situations, and highly complex. So that, I think, is understanding how to constrain those, I think, is to me one of the most pressing areas.
Terry?
It's a pleasure to be here. I'm Teresa McDonald. I have the pleasure of serving as the Chief Nurse Executive and Senior Vice President of Patient Care for the Duke University Health System. I'm also a practicing oncology nurse practitioner, so I understand both sides of the administrative side and also the clinical delivery side, and how these tools really can impact the care we're giving. I think for me, it's a tsunami. It's an overwhelming number of solutions that are coming at us at a pace that we've never before seen, and then trying to balance that in how we implement these things in a way that is not disruptive, that is safe, that is ethical, and also balancing the expectations of the end users. And it's a lot that we're trying to pull together right now in a very busy environment. Pass it on to you.
Yeah. Hi, everyone. I'm Alia Suleiman. I manage privacy, compliance, and regulatory affairs for a company called Datavant. We are a data collaboration platform for healthcare, and to give you a sense of the parts of healthcare we touch, we work with 80,000 healthcare provider organizations, all of the major US health plans, and all top 20 of the leading 20 pharmaceutical companies. And what we do is access and make data available for, really through purpose-built solutions for a wide variety of use cases, really skewing more towards the administrative burden reduction and just general administrative parts of healthcare with some clinical trials innovation thrown in. So we have the unique opportunity to sit at the intersection of so many different parts of healthcare that are using data to power all manner of AI experimentation and innovation. And one of the things that, I'm a lawyer by background. I've been a product and privacy counsel in healthcare my whole career. And one of the things that I've noticed, kind of accelerate to kind of an urgent issue in recent years is that we really lack alignment as an industry around what is high-risk AI. We talk about it in the clinical context. We have some frameworks to think about risk, thanks to the FDA and their medical device and clinical decision support guidance. But there's a whole host of administrative use cases for AI that, while seemingly innocuous at first glance, whether that's supporting prior authorization or patient access or your no-show prediction algorithm, that we've seen time and time again have, serious consequences when things go wrong. So I think this issue of how do we as an industry, then influencing our policymakers, align on a definition of high risk is one of the most pressing challenges we have today.
Excellent, thank you. And we're gonna try to segment this a little bit into patient and provider lens, guardrails and governance, and then building trust. So this is going to be our attempt here, so bear with us. It'll be rapid fire, but we'll start with Teresa on, how do you, and I don't know if you hear this yet from patients, but how do you counter patient and family concerns over the use of AI in healthcare? Is this something that's already happening, or people bring it up? How do you deal with this, or what do you say?
Well, it is coming up more and more. And the reality is that we are going to be using more AI and more technology than we ever have before. So the way we tend to bring patients and staff along is really through education, being transparent. If people have questions, if they've got concerns, it takes time. You have to pause. You have to make sure that people are really well informed. And at a time when we're going so fast, that puts additional stressors and burdens on the system, but it's time well worth taking. Because once people really understand how things work and how they're being implemented and why they're being implemented in a way that they are and how we're using them and how we're using the data and the information, that tends to ease the anxiety.
Okay. And then Ruben, if how do you scale human in the loop on the vendor side with millions of clinical settings for millions of patients and patient interactions?
No, that's really important question. And so just to provide some context on that, I think is if we posit that you can't have these errors in healthcare, there's increasing evidence that the best approaches for error reduction is to have not just humans in the loop of those that are using the AI, so the end users, but even on the vendor side or the software side, that you have humans in the loop. And so for us at Pieces, one big focus has been having board-certified physicians staffed 7 days a week to look at the output of the AI before it ever reaches the physicians who use it. And so that's very effective in reducing the error rate, but then the question of scaling it becomes really challenging. And so one is really being able to create sort of adversarial systems that will improve the quality of the escalation to the human, I think is increasingly becoming part of the research frameworks generally in the industry. Is how do you know the most effective escalation point to the human in the loop? The second is this concept of a double human in the loop. So a lot of the discussions have been, well, we're always going to have a human in the loop, and that human in the loop tends to be the physician on the ground that's taking care of the patient. That's truly not a human in the loop because of automation bias and other things. So having other humans in the loop, not just the one that's on the ground making the decisions with the patients, I think are really important. And then I think the third approach is there's patterns of errors that we're starting to see with these AI systems. And so if you have a human-in-the-loop process or a double human-in-the-loop process, that contributes very rich information that should be used to retrain the AIs. And you should never take this human-in-the-loop oversight for granted. I think you have to take every ounce of information from that human-in-the-loop interaction and apply it back to these models, or you're wasting all this kind of human capital. So we think doing those approaches, you can start scaling it to millions of interactions.
Yeah, so somebody's still responsible, and and you can send them to jail. Is that what you're saying?
Well, so you're getting the question of liability.
We're swinging over into legal.
Yeah.
But I mean, in the end,
yeah.
right? I mean, in the end, remember,
Yeah.
when you go all the way, I love to go back
Yeah.
to a physician as well, and all of us are in healthcare. We first do no harm. It also means there's responsibility. You can't put AI in jail. I mean, it's going to be, and I'm not meaning to put people in jail, but who is responsible, right? And so it's a serious thing when we're getting closer and closer to actually patient decisions and things that usually a physician would have the final word. But so somebody is in charge, and that needs to be, and ultimately, that's what you're saying, has to be.
Mm-hmm.
So
I think the controversial element, and I don't want to take too much time on this, is that when we're talking to physicians in the field, they're saying, these AI systems are very useful, but ultimately I'm responsible. And I think what they're wanting to see more is, rather than vendors hiding behind, oh yeah, we do all these things, but the physician is ultimately responsible, will vendors take the same level of responsibility? And I think what we're going to start to see emerge over time is there's going to be increasing vendor product liability for the decisions being made, and that may be appropriate. A lot to work through there, but I think that's why these systems are going to be so important.
I have to chime in here
Yeah.
as the lawyer right now.
that's your
I
prompt
hear
anyway.
product liability. It's like, I don't get my paycheck if I don't do it.
That
Yeah.
was the prompt.
So two thoughts on that. I think, and part of this is, I've worked in-house at a provider organization. We were talking earlier, I worked in-house at Epic for a long time. And I think the reality is that the case law that we have as a country around liability for software and technology companies is seriously lacking. That is because traditional products liability, think about you open a can of soup and find a nail in there, right? Like those sorts of cases are structured to focus on products, and we've historically always thought about software, specifically, SaaS models as a service. So kind of liability to the actual, like attaching to the actual manufacturer, it's been really hard to prove out in case law. Is that going to change? I think we're all here and alive at this moment in history where those questions are being raised. I mean, we have a live wrongful death lawsuit against OpenAI and Sam Altman playing out right now, associated with the, a really heartbreaking interaction between ChatGPT and a teen who took his own life. And there are really, major questions that we have to answer as a society about what we think the right responsibility shift is. Today, I think we're kind of left with what the contracts say. And to Ruben's point, I think there's a real calculus that organizations have to do when they're procuring certain tools to determine what is reasonable to shift or expect, from a vendor of an AI tool, what is reasonable to expect from our organization as the entity responsible for upskilling and equipping our clinicians to use these tools effectively. And then, you've got this extra element, and I know we'll talk about this in a little bit, of like, well, what do regulators think, right? Like, where do they think responsibility should sit? The Federation of State Medical Boards has taken a pretty firm position on the accountability of clinicians to use AI responsibly, and their AI recommendations have actually been adopted in some form in at least two states or territories, with more evaluating that. So I do think there's I always kind of think to myself that just like there's this big race across all the major AI companies to build the biggest, baddest, best foundation model, there's also this race, whether it's at the court level with regulators, federal, state, international, of like who's going to write the rules and who's going to establish the rubric. And I think it's going to be really key to pay attention to that race and those dynamics as we, again, build this conception of how does a shared responsibility model and accountability model really work?
So along the lines then, when do you seek consent from patients, or how do you even go about doing that? I mean, is there any single answer to that, or is it just a...
It's really tough, and because there's a difference between transparency, which, Terry, that I love the investment in education, because this concept of notice and just simply informing people about how these tools are used is, I think, a foundational part of any successful AI deployment, especially in clinical context. But this other question of consent, I mean, what is consent legally? It is the shifting of responsibility to an individual when it comes to how their data or their interaction with a system or a organization might influence or affect their autonomy, right? Their information, their rights. And I think it's a lot to expect of folks to really, think, okay, I put this form in front of you, or I give you a verbal prompt to say, are you okay with me using this technology in our visit? To assume that they understand what they're agreeing to if they do provide consent. That's why I think the education piece is key. We're also seeing, there's also lots of cases where consent doesn't make sense and could actually create major gaps in systems. It's one thing to consent to interacting with an AI chatbot in the course of, like initial triage of your symptoms so that you get access to an appointment, or say it's a mental health chatbot, which are increasingly being regulated. Like that's one thing. If you've got a algorithmic model that's deployed within your EHR that is tracking and scoring, a patient's likelihood of deterioration, you really don't want people to have to consent to have their data processed in that algorithm, because that could create serious gaps in the accuracy of the data and your ability to predict when particular, cohorts of patients might be at risk. And HIPAA actually, for all of its flaws and warts, 20 years, plus ago, thought about this idea of certain healthcare operations and treatment and payment activities really happening in a world without consent. And so I think we have yet another kind of challenge ahead of us to really balance this idea of transparency and notice versus permission, and kind of recognize where a opt-in model might do more harm than good.
So let's go with an example of a healthcare system, Teresa. How does your system ensure ethical use of AI? And how do you choose your partners to advance innovation? I mean, there's your conundrum, right? But you got an answer, of course.
Well, we're working through it. About 2 years ago, Duke established a quasi-national consortium or partnership with UCLA, and it was around the ethical use of AI in healthcare. And the plan was to broaden that, and there are other institutions that have joined us in that. So we've got a theoretical framework that we're working under, but tactically what we've done is in the last 18 months, we've established real cross-functional governance committees that come together: legal, ethics, clinical, our physician partners, our technology partners, and we review monthly all of the new concepts, ideas, applications, partners that we're considering bringing into our environment. Again, it's a lot of work, but this then at least allows us to try and wrap our arms around it. Now, do things sneak in periodically? Do we have leaders that go out and have a conversation at a conference and want to pilot something in their clinic? Those things always pop up, but then we'll try to fast track them through the governance so we don't slow things down, because the trick too is how do you have effective governance and how do you choose your partners, but how do you also be agile in this environment? because if you pause, if you stop, someone else is going to step in and take the opportunity.
So when we're talking about large language models, Ruben, how can these biases that might be introduced be dealt with? How do you, or you guys do it, or what are your thoughts on that?
No, I think it's this one of the central questions. I think the first is the bias. Having human loop systems obviously helps a lot to try to prevent that. I think the big bias that many people are concerned with, and I think all of us that are interacting with AI systems may notice it amongst ourselves, is this concept of an automation bias, which is the human tendency to accept as fact the information that an AI system or decision support systems present over time. And one of the biggest examples in sort of the commercial industry and the consumer industry is GPS maps, where once those were introduced, people, even when you study sort of cognitive performance, people would lose spatial knowledge and spatial memory in cities that they're not familiar with just by relying on GPS systems. And we're starting to see some of those things in AI in healthcare. There was a really important study that came out in Europe in the last month where they showed gastroenterologists using AI systems were actually descaling themselves in their ability to kind of identify polyps. So I think, to me, of the biases, there's many. You have to think about there's probably a taxonomy of 100 biases that can occur, from everything from racial bias to all the way to accuracy biases. But the automation bias to me is potentially the most pernicious. And so I think from a vendor perspective, clearly the human loop, clearly looking for patterns of automation bias. And then I think it's probably beholden on the vendors themselves to observe the patterns of the people that they're supporting to see if automation biases are occurring. And one of the things that we're doing with our clients is to look at the sort of the acceptance rate of the recommendations, and are there patterns that suggest that there's not really any thought going into the acceptance of the AI recommendation. Even though we might want to see 100% acceptance rate, that's probably not ideal. That suggests that there isn't the quality of thought there. So I think this is going to be interesting, and it's an emerging area, but clearly automation bias is going to be a huge force going forward.
So when we're talking about guardrails, and Alia, you might have some idea, but where are the lines drawn? Where should we, what needs to be subject to regulatory and legal oversight, or is there any big picture we can paint along the lines of what should be done, or what you agree with or disagree with that's being done right now?
I think what Ruben mentioned around automation bias, it kind of mirrors this concept that's been around in privacy law for a long time called automated decision making. Like essentially, there's the use of identifiable information for various purposes, and then there's the use of personal, identifiable information for automated decision making. The type of decision making that has a consequential impact on someone's life, and that could be whether you're eligible for insurance, or whether you get the job, or you pass the initial hiring screen, or simply whether your performance or productivity meets a certain threshold for advancement in your role. There's all sorts of tools that have cropped up in recent years that automate some of those recommendations, and I think we are at real risk, right, for people just blindly and sort of trusting and accepting those recommendations, or building systems that effectively go on autopilot, informed by those automated decision-making technologies. And I think that's why you have a lot of state laws primarily, taking a firm position that there are all sorts of regulatory requirements and governance requirements that have to be true and need to apply when you're rolling those things out. That includes some of the concepts we've talked about already, like notice and sometimes consent. It also includes just a robust program to ensure that, one, the organization or entity has a clear idea on what it means for this thing to work successfully, and how could it fail, and who would it harm. And that first question of what does this mean for this to work, I think for both regulators and organizations either building or using AI, that sounds like a deceptively easy question. From lived experience, you may have an AI technology where different folks in your organization have very different views on what it means for a tool to work well, and what specific problem, that's crisply defined, are you trying to solve with this functionality. So one thing that I think we will continue to see as both the federal and the state landscape evolves on this front is a shift towards use case specific kind of regulation and rulemaking, because there's kind of a general recognition that a one-size-fits-all approach is not going to work. That's why we're seeing so many of these mental health chatbot state laws crop up. We're seeing lots of state laws crop up around utilization management and prior authorization AI, and just the use of AI for particular insurance workflows specifically. And we're also seeing things crop up around what I'd call like clinical decision support generally, because there is this sense that there are these specific use cases that require a higher threshold of diligence and governance. The last thing I will say on this front is that I think there's this idea that administrative kind of use cases should just generally be put in this high impact, low risk category. We should move fast, build things. I know at Datavant, one of the things we automate is the release of information process. I don't know, who here is familiar with what release of information means? Okay, not many people. One. Imagine the millions of requests from every flavor of authorized requester that a health system has to receive and respond to. Meaning life insurers, public health departments, governments, attorneys, so many attorneys representing all sorts of interests and organizations. That is a pure cost center for healthcare organizations. Datavant supports providers across the country to do this. We've got an AI model that takes a fax or a letter, a PDF letter, and sort of maps data elements to our software that helps them digitally fulfill that record. It's you might think, okay, well, not a big deal if something goes wrong, no one's going to get hurt, except for it's a reportable incident under HIPAA for the healthcare organization. If that AI fails and sends data to the wrong requester or gets a suite number wrong on an address, right? There are little flavors of harm and deviation from expectations, even on the administrative model side. So one thing I'm hoping, and this is maybe the theme of my remarks today, is that we kind of get our arms around sort of the clinical use cases, but also don't ignore just sort of what we want to establish as a rubric for all the administrative use cases, which are just happening right now, right? That is where I think experimentation and development is the fastest, because there is no real regulatory framework or other framework just to meaningfully kind of slow it down or create some milestones. And I think we have a big opportunity to just align on what does it mean for those administrative tools to work effectively. And I think educating policymakers about that is also the next big to do for all of us here, because they only know what they're seeing in the headlines in most cases.
So we're going to switch gear to building trust. And this is for Teresa. But I mean, you can't help but just taking a deep breath when in the same conversation of AI, we also mentioned faxes. So, and AI reading faxes, and I'm just thinking, oh God. First of all, when I talk to anyone who's not healthcare, they cannot believe that these still are in existence and are being used. I mean, they think maybe it's in the back room. No, these buddies are still churning stuff out, and somebody has to deal with this stuff. And healthcare is just, in some regards, completely shot, and in other regards, we have so much opportunity. I love it that the AI reads the darn fax and make some sense of it. So actually somebody received the fax and didn't just run out of paper and it never got anywhere, right? I mean, because these things, they all have, anyway, it's just, anyway, but Teresa, for you, we're going to build trust with staff on accepting or implementing new AI, and this staff has been used to getting faxes at some level and is dealing with the realities of some of that, and at the same time we're introducing completely new things that are just right up there. So how do you involve them in that decision-making process, or how do you square that up?
Oh, there's a lot there. The trust.
Oh, we got 5 minutes.
Yeah. No pressure.
No pressure.
The trust issue is not insignificant. We've all seen the headlines. AI is going to take my job. We've also seen the alternate headlines: burnout, overburden, errors, and in trying to match all of that up, again, the key has been not to beat a dead horse, but transparency. So when we're going to be, we're actually building out 3 model innovation units at our big university hospital right now. And we've got some industry partners and some pilots that we're going to be launching around computer vision. So you talk about consent. You know, the patient, when they consent to care, they're going to be consenting for computer vision, ambient listening, all of those things. And how we're bringing the staff along is we're bringing the staff with us almost in kind of a modern day technology integrated facility design type of a model, where they're in the room with the technology partners designing how we're going to implement, evaluate, and utilize these things, and then go through a PDSA cycle on how we're going to change what's not working. So they're actually part of the design and the adoption when we bring these things to the clinic, to the clinical environment.
And we're going to keep going fast here, Ruben. Hallucination.
Yeah.
So it's one of the few things that people have heard about. They worry about it, and they appear to persist in frontier models. So what does that mean for your clinical chatbot, or how does it get dealt with, at least at the moment?
Yeah, no, this is a huge area of work, but it also can be a great area. I know there's startups and investors in the room. Like, I think it's an opportunity for differentiation as well. But it does appear that, by all accounts and all researchers that are looking at this, that even with the scaling that we're seeing with large language models, we have these persistent sort of hallucination rate that's not getting better with the increase of the large language models. And so you take that fact, and you take the fact that more and more people are using large language models to consult for healthcare information. I think we're going to see more and more chatbots being used to interface with the electronic medical record, either native to the EMR or outside. And you have this persistent level of hallucination times, let's say 100 million conversations. So when you multiply that with a persistent rate of 1%, that's a huge number of wrong clinical conversations that are going to result somewhere in death or serious disability. So I think that one of the critical areas of work has to be how do you move these constraining systems, whether it's human in the loop or other systems. For us, human in the loop is a big area, to oversee 100 million clinical conversations. And I think that's going to be a combination of, you can't just rely on large language models to be the judge either, which is one approach, LLM as judge. But I think we need to use a whole range of techniques, including predictive modeling, which is what I would call an older form of AI technology. I think there has to be there has to be this whole new set of AI workflows around escalation for these types of conversations that are occurring. So if someone's talking about anything that's getting close to some self-harm, that has to have human pathways. There's just no other way around it, compared to something that might be a medication error, which is also very significant, versus something that might be an appointment error. And so I think crafting these multi-layered adversarial AI systems, complex quality-based human-in-the-loop, and then on top of that, defined human pathways for escalation, no way around that, at least for 10 to 15 years, if not more. That's going to be the central work, I think, of the next decade for this space.
Well, as we are expiring on our timer here, and I have many, many more questions. And you have all the answers here. And as we're going into, I don't know if there's a break or not, or at least a lunch break coming up pretty soon, seek these three out to answer the rest of the questions or any additional ones you might have. Also want to call out Teresa and Alia who flew in here. And Teresa is a trooper. She flew in this morning. She's going back tonight to North Carolina. Yeah. So, this is the kind of dedication. Ruben and I, we fought traffic over here, and that's about it. So please give the panel a round of applause.